Sacral neuromodulation, SNM, is an attempt to restore the communication levels between the sacral nerves and the brain by delivering very specific low-intensity stimulation electrical pulses to the sacral nerves to restore the functions of the urinary bladder and the bowel for various control problems. So sacral neuromodulation, or modulating the neural phenomena in the region of the pelvis, is an approved kind of an indication for individuals who suffer from various known refractory conditions for which not much treatment was available in the world before. Sacral neuromodulation is actually a safe and a very efficacious, minimally invasive therapy for individuals with at least 4 indications that we work across the world. Number 1, for those who have refractory overactive bladder. Refractory overactive bladder of the kind which is not responding to a combination therapy, not responding to a botulinum toxin or a Botox therapy, and continues to have gross urinary urgency, urinary frequency, also amounting to urge incontinence of the kind which cannot be controlled by medical managements and by minimally invasive therapies. So patients who have got urgency, frequency, urge incontinence, or overactive bladder are normally treated with behavioral therapy on one side and on therapies which help to pharmacologically modulate the activity of the bladder, which is overactive. This overactivity of the bladder, which we attempt to treat with medical managements and behavioral therapy, with a lot of help from the patient, helping us out to modulate this by a behavioral therapy of taking care of herself and himself, perhaps does not help in all the cases. There are those refractory overactive bladders with gross urgency, frequency, urge incontinence, even after the full dose of medication that's available for the human beings doesn't act on them. These kind of refractory overactive bladders on urodynamics shows an increased activity of the bladder during the filling phase when the bladder needs to be silenced. And that activity can be only brought down by either botulinum toxin injection, which at the Kokilabenhospitalmumbai Hospital and Department of Urology, for all refractory overactive bladders who don't respond to a combination therapy or a full entrenched therapy over the 3 months to 6 months of continued attempt, are injected with botulinum toxin into the urinary bladder under anesthesia by a cystoscopic method, and they continue to succeed in X number of percentage of patients, but not in everybody, would actually require a therapy beyond it into a niche area of therapy. A therapy which could help us modulate the entire activity of this neural mechanism which has gone haywire and the bladders are contracting erratically. That erratic contraction leads you to an involuntary, unpredictable leakage of urine or frequency urgency, which is difficult to postpone. So friends, refractory overactive bladder happens to be a situation where not able to control urine and leaking urine at odd times, odd hours, and just nothing therapy is working around in this. So in the prime of life between 30s to 60s, individuals have got gross frequency, urgency, urge incontinence, failed all therapies, could possibly be the first most important and labeled indication for sacral neuromodulation across the world. And in India, at the Kokilabenhospitalmumbai Hospital, where we start this, in fact, restart this program of sacral neuromodulation with a big bang, we look forward to making this awareness very important, because many people live in agony, live with incontinence rather than leave incontinence because there's not much therapy available beyond a point in time. The second group of patients who would benefit from this very efficacious and a safe minimally invasive therapy called sacral neuromodulation are those patients who don't have an obstruction to the flow of urine. They may have a poor flow. They may not be able to empty the bladder and are called as non-obstructive urinary retention, or NOUR. Non-obstructive urinary retention individuals are those who probably are not able to empty their bladder, not because there's an obstruction, but because the bladder's capability of pushing urine out, or there is a kind of mechanical change happening in the musculature which does not let the urine to empty completely, are those individuals who have a high residual volume on sonography. These are individuals who are not able to empty the bladder because of umpteen reasons. The common reason that we see sometimes in women is called Fowler's syndrome. Fowler's syndrome is an individual who possibly postpartum, post-pregnancy, post-delivery, and also a young female otherwise too, could have an issue of such a neurological vagueness where the bladder does not empty. She attempts to empty, she fails. She needs to be on intermittent self-catheterization or sometimes to live on catheter. The emptying mechanism has somewhere gone haywire at the region of the closure mechanism, at the region of the compression mechanism. These people have a variability in their entire attempt to flow. And there's Fowler's syndrome, which is again a case of non-obstructive urinary retention or unable to empty completely, has been a great leveler in this sacral neuromodulation therapy across the world. Obviously, unfortunately, there are only anecdotal case reports exist, but an individual who's suffering and not able to get an answer of this could be a great answer by a sacral neuromodulation. We are attempting to modulate the activity of the sacral nerves input into the bladder and the bowel so as to eliminate the symptoms of the urinary bladder and the bowel. The third and the more important indication for the world has also been on incontinence in the bowel. Fecal incontinence. Imagine you have an incontinence of urine and there is a diaper you wear and there is a continence mechanism medications available which is started orally, and then there's a botulinum toxin injection. But for fecal incontinence, where the feces just can't be controlled and you leak out feces all the time, gross and refractory, there's always a challenge around. And that kind of individual with fecal incontinence or a combined fecal and urinary incontinence where the bladder and the bowel mechanism is completely haywire on the nerve activity probably would require this to be taken forward. This aspect of a treatment or a care by neuromodulation has been a great leveler, and probably more and more patients are opting for this. Obviously, it's a niche area of therapy, then only in few centers across in any place, and will have to be taken care of with a lot of understanding. When we look at sacral neuromodulation or neuromodulating the understanding between the sacral nerves and the brain, thus bringing about and eliminating the various aspects of changes which have happened in the bladder and the bowel mechanism, especially in the control mechanism of the bladder and the bowel, so that individuals are leaking urine, individuals are leaking fecal matter or stool is getting leaked out. It is important to look at those neuromodulation. So what does a doctor do? What do we do in such patients around? Having looked at the refractoriness of the condition which is not getting medically treated, we look forward to treat these individuals by identifying and understanding that this can be taken forward to the next and the final level of therapy before any surgical care is brought about. Not that we don't do surgery for such patients, but this is such a minimally invasive therapy where in the operation theater, we are under very sterile mechanisms, under a C-arm guidance, look at the sacral foramina because it's a sacral neuromodulation. Sacrum is the area at the back, on the lower back, where the lower pelvic nerves go and innervate the urinary bladder and the bowel and the pelvic area. That's where we would be able to, with a very fine needle under mild sedation, be able to reach and modulate the nerves by stimulating the nerves and look at the effect on the table itself. So imagine you're going through urinary incontinence, urinary retention, not able to empty your bladder with no obstruction. You have got fecal incontinence and you are not able to manage this. And in that situation, if you have something to be done as good as this, how do we handle this? So we look at neurostimulation by a lead, by a small lead which enters through the sacral foramina, and it's completely painless. Once it goes there and it stimulates the nerves, the effect of the nerves are seen on the anal verge and on your toes. So the S3 nerve, which is the most effective nerve stimulation that has been practiced across in sacral neuromodulation, is stimulated. It's stimulation by a tiny lead which goes parallel to the nerve S3 and stimulates the nerve to bring about effectiveness in the kind of mechanism on the relay of the neural impulses to the brain and therefore to the end organs, bowel and the bladder, brings about a significant change. That change can be seen if we have seen the changes on the operating table. So those patients whose changes can be seen on the operating table by just putting that fine lead on the sacral foramina and testing out S3 and S4 levels under local anesthesia with minimal sedation and looking at the sensory and the motor responses could be candidates into the therapy of the refractoriness that they're suffering in the urinary control or urinary retention or painful pelvic floor or issues of fecal incontinence. So friends, when you look at this sacral neuromodulation, you almost have an effect on the table instantaneously to be seen by the team. And if that is seen, then we go to the next step. That means we probably fix up those fine leads at the back, tape it completely, and then give you a time of a week, 2 weeks to be home under normal circumstances with everything, those fine wires fixed at the back. Doing so, we are in a position to look at the effect of that happening over the next few days to a week to 2 weeks. And that's a time you are able to judge for yourself. You're able to bring about bladder diaries and help us your leakage, your retentions, etc. have got better. your urinary and fecal incontinence has got better, to a level where we can now go ahead with stage 2, which is the interstream 2 implantation of that battery, which is a battery that lasts for 5 years. At least right now, that's what is available. And that for 5 years, you could be having an effect. So what are we looking at? We're looking at individuals with 4 major indications who go through this situation and probably have a dead end in their life. They have no more therapies available. And there's a therapy available right now, which was always there. Perhaps we never talked about it. Perhaps effectiveness were never tested in large trials around. And perhaps each individual matters in whom we can test out. Test on the table itself. Give it a week or 10 days of testing. Identify and understand them. Then are they the right candidates? And then go ahead with an effective final placement of that small battery, just 12.5 cc, approximately 2.5 centimeter of a battery, which is implanted in your back as if a pacemaker, which is probably giving nerve impulses and electrical modulation, and therefore doing a neuromodulation to the sacral segments, which supply the nerves effectively to the region of the pelvis, so the bladder and the bowel. So friends, sacral neuromodulation is here to stay. It's a labeled kind of therapy used by the US FDA, and therapies have been done across the world. If I gather from data, more than 325,000 patients have been implanted across the world in various countries, including India, where we implant this tine lead, look at the effectiveness, prove the effectiveness to ourselves and the patient, look at the changes happening over 10 days, 2 weeks at the max, and then implant the main device and fix it up and let them go. This entire aspect is then neuromodulated by programs, and the program best suited out of the 7 programs available can be done by a monitor, by a Samsung phone, or by a neuromodulator device which is given to them. The batteries need to be charged. The batteries are charged like you charge your mobile phone once a day. You could charge your battery once a week. And that is the way you take your journey into this 5 years phenomenon. There is a possibility in due course of time, there could be rechargeable, there could be non-chargeable batteries. There could be various kinds of aspects which would come in. But at the point in time, the state of art that exists is for 4 individuals. Number 1, those who cannot control urine at all with any therapy available. That means they are refractory overactive bladder, failing all therapies, nothing working in them. Number 2, voiding dysfunction, where you cannot void or cannot pass urine, dysfunctional voiding, which happens mainly with a non-obstructive phenomena. There's no obstruction visible. There's no obstruction by the prostate. There's no obstruction at all. That has been cleared or that was never there. So women have no prostate, and therefore if they have got high residual volume and cannot empty completely and could be fitting into that or could fitting into a subset of NOUR called as Fowler's syndrome, they could be candidates where you can modulate the neural activity in the brain and get them to pass urine, empty their bladder, the residual volumes come down. We look into the other aspect of individuals on the NOUR in India, where diabetes is unfortunately very common. People in the diabetic journey with 10, 20 years of diabetes and beyond have a bladder which has got a lesser sensation and lateral contraction power. These bladders are hypocontractile or acontractile. Those bladders which have got some power have subnormal detrusor pressures and perhaps can't empty by any other mechanism available of the attempts that we are doing in the country are best fitting into this indication of refractory urinary retention, not able to empty, but there's no obstruction to the flow. So non-obstructive urinary retention or NOUR is going to be a large indication in India because India has a huge population in middle age and elderly who have got a high volume of urine left in the bladder after a flow or whatever they can empty. These patients sadly live on catheter, they live on suprapubic cystostomy, get recurrent UTI because they can't empty their bladder, interferes with their entire mechanism, host mechanism and their life. They all sometimes live on diapers and cannot empty completely. The patients who would also fit into this are those who see us for fecal incontinence. That means the fecal matter is leaking around, urinary matter is leaking around because the entire neural activity on the bowel is poor. And fecal incontinence is a labeled indication across the world. We have seen such patients coming around and requesting. And those patients who have got fecal incontinence deserve to be getting a neuromodulation as a therapy, which neuromodulates, changes their life, the diapers comes off, and they lead a better life. And finally, that I look at interstitial cystitis, bladder pain syndrome, not of the kind where they have got Hanna's lesion, not of the kind where they have a very small bladder capacity of 150, 200 or 100 ml capacity where you need an augmentation cystoplasty to make a new bladder. But all those women and men who have got a normal bladder capacity, who don't have any major lesions in their bladder, who have got a high pelvic tone and who possibly cannot empty their bladder. That kind of a situation where the bladder is going to be making you discomfort and pain, where the pelvic floor is pain full and you have got a bladder pain syndrome, which is happening with high pelvic tonus. The pain is in the region of the perineum, in the region of the pelvis. There's a kind of a constant pain, a pain which is very erratic, which with neuropathic medications and injection therapies by your pain therapist is not giving you good result. At the same time, the urgency, frequency, urge incontinence is forced upon you by the bladder, which is giving you discomfort and pain. Maybe a great indication. Not much study has been done and therefore not much publication has been done around, but I know that we are dealing with almost being a diabetes capital of the world, almost being a bladder pain syndrome capital of the world, with more and more patients having not got the right treatment, partly because the treatment was not available, the awareness was missing. More and more patients in bladder pain syndrome got a treatment of their flare, which is more of a UTI or maybe not a UTI, and missed out diagnosis. So friends, when you look at sacral neuromodulation in the country, from the Kokilabenhospitalmumbai Hospital Department of Urology and few centers in the country which would do sacral neuromodulation, the niche area of this therapy in a minimally invasive approach, which is safe, efficacious, which gives you as a patient and us as urologists and team members in the neuromodulation, will help us to identify this on the table. That means you have a test stage as first stage, and then you have an effective permanent implantation. So the test stage over the next 7 days, 10 days, 2 weeks, we will be in the operation theater. After that, half an hour, 45 minutes of procedure, implanting it when we have got the effective kind of bellows, effective kind of plantar flexions around, attach the entire leads and given you a time to go back home, look at changes in life which happens around, we'll be in a great shape to take it forward to the next level. Sacral neuromodulation is here to stay. Therapy which has been difficult for a reason that it can be an expensive therapy, but it changes your life. And that is a change we aim to bring in quality of life of individuals who are living with incontinence. They need to leave incontinence, both urinary incontinence and fecal incontinence, and go to the next level completely. Thank you so much.